Good evening. My name is Jaco Laubscher. I'm a physician in private practice at the Stellenbosch Mediclinic in South Africa. I'm here today to try and convince you that the management of COVID-19 is an important factor and we should stop barking up the wrong tree. This is a vascular problem and not a respiratory problem. Tonight I'm going to try and convince you of that fact and hopefully equip you better to save lives. All over the world, reports were found that there's some anomalies regarding these patients. Patients become severely hypoxic despite having normal lung compliance. Increased reports of thrombotic complications in spite of therapeutic anticoagulation, usually using heparins or low molecular weight heparins. And poor outcome of patients that progress to full ARDS despite optimal therapy. Consistent finding of thrombi in the microcirculation of the lung on post-mortem studies. If we look at the elementary unit, functional unit of the lung, it's basically an alveolus and a blood capillary, and that's where gas exchange happens. So if you look at these patients clinically, you listen to the lungs, there's actually not much sounds to be heard. The patients have got a normal mechanism of breathing, and early on when patients are being ventilated all over, intensivists would tell you this is hot. The patient's ventilation is actually quite easy, normal lung compliance. So from that we can deduct the compliance of the lung, the alveolus is normal. So if the patient is severely hypoxic, the only thing left is the vasculature. So you've got a blocked blood vessel proven on post-mortem studies, and that's why the patients become hypoxic. So there's evidence of microthrombi. So where do these thrombi come from? All the evidence again points to a thrombotic microangiopathy, which just means small blood clots in small blood vessels, the capillaries. If we then look at the question, what is a thrombotic microangiopathy? We said, well, let's try and find a model to try and help and explain this. And the only model I know of is a disease called TTP, thrombotic thrombocytopenic purpura, to try and explain this. And on the other hand, we said, well, we need to look at clotting and the whole physiology of clotting. Looking at thrombotic thrombocytopenic purpura, there is an abnormal interaction between ADAMTS13, a protein in plasma, and von Willebrand factor, leading to macromeres of von Willebrand forming, platelet aggregation, and that causes the thrombotic microangiopathy. Together that usually you see a consumptional thrombocytopenia. So let's go back to the clotting cascade. There's of course two parts of it. On the one hand, you've got the enzymatic pathway, and it's a cascade of activation of clotting factors, in the end producing thrombin. This pathway is monitored in practical terms by doing certain tests called the APTT and INR, amongst other things. And what actually happens is a sample of blood is taken from the patient, the blood is centrifuged, so you're getting rid of cells, amongst other things platelets, and you're left with plasma. And on that, these functional tests are done. That tells you, in fact, then nothing about the platelet function. So the next leg of clotting is the platelet pathway. Platelets are normally inactive, a small little disc like a UFO, but when it gets activated, and the big factor there is von Willebrand's factor, amongst others, you get a number of changes to platelets. They become adhesive, they activate, meaning changing shape, degranulating, and pushing out receptors to try and tightly bind with each other and also underlying tissue. This activated platelets then forms aggregates, and in the end you're stuck with von Willebrand platelet conglomerates. So forming a clot means combination of fibrin with von Willebrand factor platelet conglomerates and forming a nice tight clot and repairing the injury. So after that introduction to normal clotting physiology, I found a short video to just explain to you what we've gone through by now. Have a look.
In a first step towards clot formation, platelets are recruited to the site of vessel injury by now exposed molecules of the vessel wall, such as collagen and von Willebrand factor. This factor mediates the linking of platelets to collagen via a specific receptor in the platelet membrane. The resulting change of shape of the platelet from its resting state into the dendritic form indicates activation. The activated platelet in turn releases prothrombotic molecules such as adenosine diphosphate, ADP. By binding to its receptors, ADP induces aggregation. And recruits further platelets to the site. Thromboxane is another important mediator of platelet activation and aggregation. Under its influence, the platelets cross-link with each other. These interlocking mechanisms cause platelet activation to snowball. The clot grows rapidly. Activated platelets also trigger the coagulation cascade and thus the formation of thrombin. Thrombin, in turn, stimulates platelet activation even further, a continuous feedback loop. Additionally, thrombin induces the formation of fibrin for the mesh stabilizing the clot. The self-reinforcing process of platelet activation, crucial in the formation of blood clots, is an obvious therapeutic target in conditions caused by inappropriately triggered blood coagulation.
Like many things in the body, there's always balance, and that goes for clotting as well. So it's important for your blood to clot, but if clotting is allowed to continue unopposed, you would get complete clotting of your whole vascular system every time you have an injury. So the body made a plan. In the area of injury where you have clot formation, the body starts breaking down the clot with a process called fibrinolysis. Important factor there is the plasma factor plasminogen that binds to clot. This is activated by TPA. TPA coming from endothelium, remember that, with the eventual product of D-dimers, broken down fibrin. Having said all that, one can immediately understand that if there's an abnormal or diseased endothelium, you're going to get problems with hypercoagulability on the one hand and reduced thrombolysis on the other hand. So having said all that, let's get a bit closer to the bedside now. So looking at healthy arteries, we do a test called the carotid Doppler study, and basically with ultrasound we go and measure the thickness of the intima. That gives us a pretty good idea. It's not 100%, but gives us a pretty good idea what's going on in the patient. And believe it or not, the patients at highest risk of having an abnormal intima are the high-risk patients, the elderly, the diabetics, the hypertensives, the obese patients, patients with ischemic heart disease. And believe it or not, these are the same patients that develop serious, severe COVID-19 disease. And surprise, surprise, patients that does well with COVID-19 are those with a normal, healthy endothelium, kids and healthy adults. So trying to explain then COVID-19 thrombotic microangiopathy. So in fact, it's not a COVID-19 pneumonitis. It's not a lung disease. It's a vascular disease. It's infection of the virus directly on endothelium using the ACE2 receptor, and in a vulnerable endothelium causing an endothelialitis releasing von Willebrand factor massively so. It's been reported von Willebrand factor levels 600, 800% of normal, activating the platelet storm. So you get von Willebrand factor platelet conglomerates leading to the thrombotic microangiopathy. So COVID-19 coagulopathy is actually just failure of the normal physiology of a diseased endothelium, leading to hypercoagulability on the one hand and impairment of fibrinolysis on the other hand, and you can't win that situation. Therefore, we conclude that severe COVID-19 disease is a vascular disease and not a respiratory disease. So, having said that, it immediately made us think about possible treatment targets to manage this and, in fact, to control normal physiology on behalf of the patient who is lacking the ability. To do that properly, you need to measure. This is not flying blind. You need to know what is going on with whole blood clotting by just measuring APTT, anti-factor 10A activity. You're looking at the enzymatic pathway, and by giving more of the same, you won't control this hypercoagulable state unless you look at the platelet pathway as well. Specific tests are available for that. In fact, an ancient test called the thromboelastogram, and I predict this will make a big comeback. And in fact, if you don't use a TEG, it's not a difficult test to interpret. You will not be able to manage these patients. So on the one hand, looking at TEG, and the other, the platelet functional assay, the PFA 200. So therapeutically, you still need to block the enzymatic pathway of clotting, and you can choose whichever drug, I believe, whichever drug you prefer, be it heparin, low molecular weight heparin, the DOACs, even fondaparinux. But on the other hand, you need to calm the platelets down, and you need to block the platelets with probably at least 2, maybe even 3 agents. And this you can manage, this you can measure. It's not flying blind again. The platelet functional assay tells you the 3 channels of the platelet that needs to be blocked to prevent platelet hypercoagulability. And that means the collagen epi channel for aspirin, for instance, the P2Y channel for clopidogrel, and the collagen ADP channel for the GP2B3A inhibitors. If you've achieved that, your TEG tells you the patient is still hypercoagulable, clinically the patient is doing badly, hypoxemia, tachypnea, you need to get rid of the clot, you need to do thrombolysis. So it's like saying to a patient, well, you've got a clot, but maybe I'll treat you only in 2 days' time. You want to get rid of the clot now, so why wait? Ventilating a patient is not going to make any difference to the patient. So with all this in mind, we developed a managing protocol, and I can report on my own small cohort of 20 patients, of which 2 admittedly were mild COVID-19 disease, but 18 of them moderate to severe disease, according to CORAD's CT scoring system. Only 1 patient so far needed ventilation, and that was our first patient. And unfortunately, that was the only patient that we've lost. And so far, we haven't needed to ventilate 1 patient at all. And by seeing this fantastic outcome, we are very optimistic that this is the right way to go. And you can even see in the wards, the staff, the fear of managing COVID has disappeared. This is not difficult to manage. And I hope you will take this short video to heart, develop your own protocols, and change the way we treat COVID-19 patients to save lives. I thank you very much.